Okay, well, I guess we're live now. Hello there. I'm Dr. Stephen Broughton, National Chairman for Kappa Alpha Psi Health and Wellness. And today, we're going to have a great host. I mean guest. I guess I'm the host. But we have Dr. Robert Wynn, who is a specialist in pulmonary diseases, and he's going to give us a great deal of information today on lung cancer. This is part of our series that we want to do for Black Health Matters, which we thank them for this opportunity to present ourselves and present our specialists to men and women in this country on the importance of healthcare in our African American communities. Welcome, Dr. Wynn. Can you briefly tell us about yourself and your Cancer Center and your work with the National Institutes of Health and the African American community?
Yes, I want to first of all thank you all for hosting me. Kappa's, all of us, Longevity for sponsoring this, as well as Bristol Myers Squibb and the NPHC. I think that this is an important topic, particularly of lung cancer and COVID, because both of those really have negatively impacted the African American community, and particularly that when we think about African American men. So this is an incredibly timely sort of discussion. I am currently the Cancer Center Director of the VCU, Virginia Commonwealth Massey Cancer Center. Massey Cancer Center was one of the early cancer centers in the United States that had something called an NCI designation. So I remain, unfortunately, in 2020, the only African American Cancer Center Director of an NCI designated cancer center in the United States.
Outstanding, outstanding. Have your operations changed or adapted over the past few months? And can you give us a little bit more in detail about that?
Yeah, I think all of us have had to, particularly with the COVID pandemic, we've had to make some some changes. One of the changes is that we recognize absolutely that clinical trials are necessary. In fact, I would say probably pre-COVID, many of us had been talking for years about the lack of African Americans on clinical trials and what that actually meant, particularly in cancer. And that while we were coming up with discoveries, some of the discoveries weren't always applicable to everybody. Interesting enough, in COVID, it now was quick that if we didn't treat and we didn't have clinical trials, we wouldn't be able to treat anyone. Why is that important? It also turns out that one little secret was the reality is that the additional reason why most African Americans weren't on clinical trials had nothing to do with us. Not directly. It was because we had what's called comorbid diseases. And you probably heard that from Dr. Fauci when he talked about having hypertension and diabetes and all these other things. Well, historically, those kept us out of clinical trials. Now, you can imagine what would have happened had African Americans not been included in the COVID trials because they had diabetes or because they had hypertension. So I think that what COVID has done is it's certainly made us change the way we do business. It's actually also brought about a new reality that clinical trials aren't just for wealthy white folk; they're for everybody, and that the results we get from them matter.
We're so thankful that you are providing this information for us, because one of the things that I tell all the brothers all the time is I am my brother's keeper, and we have to let each other know how important these things are, because in African American communities, particularly, and in lower socioeconomic communities in general, we have more of the comorbid type of diseases and processes that affect our healthcare a great deal. Can you share with us the prevalence of lung cancer and respiratory illness in the African American community?
Yeah, we're unfortunately still, have the leading cause of cancer still remains lung cancer for both African American women and men. And when we think about our respiratory illnesses, such as, COPD, asthma, you can name them, almost in every category, you're putting African Americans number one.
Yes.
Not the category that we want to be number one in, but
Exactly.
but it happens that, whether you're talking about diabetes, hypertension, but certainly in the respiratory illnesses, as we just talked about, COPD, asthma, and lung cancer, those are still led wide by far by African American men.
Now that we're in this pandemic crisis with COVID-19, are there any particular things you can tell people about protecting themselves, and as well as those that are currently in immunotherapy or other types of treatments at this time?
Yeah. So let me start off by something that you're not going to hear about protecting yourself. Get good information. That's one of the key ways we can protect ourselves and our communities. And I mean that. At the beginning of this COVID crisis, we had crazy information, misinformation, disinformation, and I don't really care who it came from. But the information that African Americans could not get COVID, nor could they have an negative effect from getting COVID, you and I know that was widespread throughout our African American communities. Yes,
definitely was. Since we provide the information here, let's go with the basics. What are the signs and symptoms of lung cancer patients to begin with, and then what do they need to consider in evaluating themselves with the COVID-19 at this time?
Yeah, so I think with COVID, it's going to be the same classic symptoms. If you have a cough, if you have headaches, if you have a fever, if you have, joint pain, muscle aches, it's COVID until otherwise known. So when we think about our cancer patients, that's harder with lung cancer. This is why screening becomes really important, because lung cancer, for the most part, doesn't present really as almost anything. You may have a cough that goes more than 3 months. So I would say if you had a cough that's persistent, that goes for more than 3 months, you certainly ought to get checked out for sure in the context of lung cancer. In the context of COVID, it really is those regular symptoms that we've been, more familiar with now than we were at the beginning of this thing. And going back to your first question, in addition to being armed with information, one needs to be social distancing. May not be popular, but it saves lives. We're obviously seeing that right now as we see a spike in Arizona, spikes in Texas, spikes in South Carolina. Carolina, actually, I just went over 22,000 cases today, and they had been at a very fairly low level. So the reality is social distancing is still the order of the day. Second, when it comes to protecting yourselves, masks. And why would you wear a mask? You're wearing a mask I would say, for two different reasons. One, to protect yourself, but to show someone else that you care about them enough to protect them by you having a mask.
Exactly.
So let me run down the mask real quick, because I don't think people really get what the masks are. An N95 mask, let's just get real with it, means it's 95 because it means 95% of the particulates that you actually are talking. And let's get real about how you actually produce this. It comes from talking, from singing, from yelling, from coughing, which we all know. The reality is, if you are in an elevator with someone and they're coughing, yelling, singing, or you're in church, let's get real with singing, or the loud delivery or spoken, you are delivering particulate matters, just the way it is. So your N95 mask will get rid of about 95% of those particulates coming out. The regular surgical masks that we actually are familiar with, those masks roughly get between, I would say, anywhere between 75 and 85% of the particulate matters, and that's good enough. The cloth masks, sometimes, depending on what and how they're designed, may get 50%, but they're probably not getting up to probably about 70, 75%. So let's just say that as you're wearing masks, that also should give you an idea about how to protect yourself. And last, I think we recognize that COVID is predominantly transmitted through respiratory sort of particles. That's not to say that it can't be by touch. We're still figuring that out. We know that we had a study from UCLA that said if you were to touch a cardboard box, it would still be there. At least elements of that would be there for 72 hours. However, the bottom line is, I think our grandparents had it right. Cleanliness is next to godliness, and we need to stay.
Indeed. I'm so glad you mentioned that, because the number of people that I see that are wearing masks, and some of them have it covering their mouth only, not their nose. It's just incredible that our lack of information that is causing us to be just as concerned as if you're wearing the mask at all. But thank you for pointing that out. Should individuals come in more often for routine screening than they normally do? Getting men in particular to go for routine screening is difficult. They tend to be a little stubborn and they don't want to go to the doctor's office.
Well, sometimes getting into full-blown COVID remains difficult to get people into the hospital. So, so let me share with you one of the crazy things that's happened during this COVID period. We now know that as a result of COVID, less people are going into sort of seeing doctors. And you might say, right, why would you go into a doctor's office? Because why would you go someplace where you might see and run into a COVID patient? I get that. But here's a result, a real result. Two things are now happening. The first is that we have more people dying at home, and I mean that, dying at home with suffering from heart attacks and cardiovascular disease as a result of their fear from coming into the doctor's office. Second, what I'm worried about with lung cancer in particular is that we probably have more people staying away who probably ought to get screened, 55, if you have actually, smoking 30-pack years, if you actually are having a cough that's been there for more than 3 months, and you're a smoker, to not come in to get screened is insane. In fact, my fear is that what we're going to find is that we're going to have increased numbers of African-American women and men dying with later stage cancers, particularly lung cancer, because of their fear from coming in the hospital. Here's the reality. Hospitals and clinics have never been cleaner. I mean, I have been around the block for at least a little bit, and I can tell you that the type of methodologies and approaches that they're having to cleaning their offices, cleaning, the rooms that they see you in, have never probably been as tight and clean as they are now. This is not the time to sort of be afraid to go to see your doctor. Do folks need to come in more? I'd probably say, I would say not more screening, but I do think that if you're having symptoms of COVID, or you think you're having symptoms of COVID, or you got direct exposure to someone with COVID, you should get that checked out. And I think from a cancer perspective, if you have a cough, again, that's over 3 months, that's not going away. If you're having some weight loss, coughing up blood, you should get that checked out. And for goodness sake, if you know you're a smoker and you know who you are, and I'm not pointing any fingers because it is a habit. It's not a habit that you were born with. It's a habit that you acquired and got hooked on to get that. So there's no judgment here. But if you know you're a smoker and you have a chronic cough and you have just that sense of feeling that something ain't right, get checked out. Don't be afraid. You're probably less likely to get COVID these days from the hospital than you are from going to the shopping mall. Or from
Indeed. I think we have a question from the audience. Okay, from Steady Rock. Can pulmonary embolism lead to lung cancer? In other words, do clots in the lungs lead to cancerous cells?
You know what? I appreciate that question, and appreciate you. It's the opposite. If I usually see pulmonary embolus or clots in your legs or clots in your lungs, that makes me think that you have cancer. Why? Because what happens is cancer also not only messes with your lungs, but it messes with your vessels in a way of disturbing them and messing up the architecture so that the blood flow sometimes gets slower and you're more likely to actually develop clot. In fact, in the old days, we used to call that the clot burden, that we could tell the progressiveness or the stage of your cancer, whether it was early stage or whether it was late stage, by the amount of pulmonary embolus and clots in your body. So it's a great question, and it's one in which definitely if you're having, clots in your legs, clots in your lungs, one of the things we immediately go to think about is that related to some occult cancer, either through your lung, prostate, GI, but bottom line, it's a signal that we should worry about something.
Great. I think we had another question from Jean Regnite. I'm sorry if I mispronounced your name, but her question is, where is the public health messages for communities at risk? Can you comment on that?
I mean, from a public health thing, we've got out of the block slow. So let me just be straight up honest, and as they would say, where I come from, keeping it 100. In that context, we have probably not done a great job from the beginning of the COVID crisis in the context of our public health messages. And we certainly have not always done a great job around our public health messages around cancer. So the crazy thing about COVID is that I think we are finally getting to that point where we are starting to see commercials about wearing masks. We are starting to really kind of have the beat of the drum about social distancing. And all these things are going to have to come into place until we have a vaccine. Right. While we have a treatment, remdesivir, it is not a substitute for a vaccine. And so at this point, bottom line is, I know it sounds 14th century like, but the best way of keeping us all safe from a public health perspective and keeping our churches safe, our community safe, is just good old fashioned hand washing, masks, social distancing, and keeping things clean.
You know, one of the things that you know, we've both been to the National Medical Association meetings for a number of years, and one of the things we've always talked about for a number of years has been the health disparities in minority communities. COVID-19 is just making them come to light, because we've always known it. So it's just a shame that it took a pandemic crisis for this to be addressed. But I guess it's better late than never.
Better late than never. Better late than never. You know, I think the other sad part about that is not only did it take a pandemic, but it took a pandemic. It took the 8 minutes and 46 seconds of an actual individual get snuffed out in front of us. You would argue, George, Trayvon, we could talk about Eric Gardner, but you saw snippets of that. This is the first time that we actually could not turn our eyes away. And then last, it took, I call it the Triad, to not only, being woke is one thing, but being active is another. And hopefully with the pandemic, which blew it open, it was undeniable that there's disparities. There was the 8 minutes and 46 seconds that Brother Floyd actually had to endure. And then last, it was this issue around our Amy Cooper. I always been telling folks, look, you better watch out for the Amy Cooper inside you. Now, if you don't know it, Amy Cooper went viral, but she is a young white woman who graduated from University of Chicago, top institution, was a liberal by all sort of a stretch of the imagination, supported Obama, supported Biden. And yet when I think Christian Cooper was just bird watching in Central Park, and essentially told her, you should probably put your dog on a leash. And she responded, I will call the cops, knowing full well what that could have actually. So I think these three things together has now, as a trio, if you weren't woke before, you are woke now. But beyond woke, we got to do something. Exactly.
If someone has lung cancer and is exposed to the COVID-19, I think a question that was asked, will they develop another type of infection, or is that totally unrelated? Or could you kind of give us a little brief summary of your thoughts about that?
Yeah, at the beginning of this, and we're still trying to have the data vet this out for us, but it appears that at least some of the work that was from the early work, particularly in places like Spain and Italy, that if you had lung cancer, you were actually more predisposed to actually having a bad outcome if you had COVID. Another way of saying that is that the vast majority of the deaths, when you go back and looking at the data from Spain and the data from Italy, showed that if you had lung cancer in particular, that your outcome was significantly reduced by having the cancer with COVID as just having COVID alone. In the United States, we're still trying to comb through our data. As you know, I think that we've been, the best way to sort of say it, we got caught flat-footed.
Yes.
And we're now trying to get back on our toes to sort of put all these things together. But I think in a similar way, it'll likely turn out in the United States. And when we go back over our data, although I don't have the data to say that at the moment, people will look at this. But I do know by both the Spanish and the Italians in their experience, among others that are now coming in, that lung cancer certainly in the context of COVID puts you more at risk for having a bad outcome.
As the states are reopening, even though they're not sticking with their own guidelines, but the states are reopening, what advice can we give our listeners about attending church, family gatherings, and other things? We're coming up on another holiday, and also people are stir crazy in their homes now, but the restaurants are starting to open, beaches are starting to open. What advice do we really want to make sure that people have at this time?
Now, I would say something nice like, oh, it's probably going to get better. But let me just come straight up, keeping it real, right? As we repopulate our churches, and just for the record, I, with Pastor Gray and a group of people here in Virginia area, we have a Facts, Faith Friday meeting every Friday, so that we are talking about not what we think, but bringing the experts to the table to give us the best possible information. And here's what I do know. Things are going to open up, and it's not as if COVID's going to last for 100 years. There is a discipline and a rigor and a commitment and a type of thoughtfulness that's going to have to go with all African Americans and all communities beyond even African Americans about how much do we care about each other to save our own lives.
Exactly.
And so in Virginia, I was like, I don't really care who opens up, because remember, at that time, North Carolina, South Carolina, these people were like, they're going to open up. The governor were asking, folks around here, well, what should we do? The truth of the matter is, in heavily concentrated areas where there's a number of people, whether you're a mid-tier city or a highly densely populated area like Philadelphia, the truth of the matter is the virus ain't gone nowhere.
Exactly.
The virus has not taken a break. And the funny part about that is I tell other people that cancer came before the virus. Cancer is still active now, and cancer will be active well after the virus is under control. But this virus isn't gone. So you could fool yourself and have that kind of conversations. And I hate to, get real, but I don't know how else to communicate. I could give you all the highfalutin explanations of this, but the reality is COVID's still there. And
brother, we have to get real. We have to get real. And people want us to be real because this is a real serious time right now. Yeah. We have some more questions from the audience.
And sorry that I'm so passionate around these things, but I really, healthcare matters to me, and our health matters to me a lot.
Well, that's why you're here, because you're passionate about it. Thank you so much for being passionate. From Mike Bradley, given the history of distrust of the Black community and the healthcare system, especially with clinical trials such as the Tuskegee experiment, et cetera, how do we get more African Americans to participate in clinical trials so that we have evidence-based data for the medical community?
Yep, I love that question. I think that's an outstanding question. I'll break that down into two parts. The first is, you're right. And in fact, the medical community as a whole, it's not just Tuskegee, it's so many other things that for going all the way back to the fact that they used to do, because they thought Black people didn't have pain receptors like regular people. They did open surgeries with no anesthesia. So this thing about medical mistrust has been here for a long time. But let me also remind you that we know that, and they've been putting things in place. So here's the saddest part about this, that people were doing things to us unethically. But while we're on the verge of actually breakthroughs of miracle drugs in which ways I had never thought possible as a medical student, those things are coming all because of clinical trials. The immunotherapy that many of the well-to-do Caucasian counterparts of us will have access to these trials and life-saving trials. And the fact that because of our distrust and mistrust, we might miss out on some of those miracle benefits is also sad. In the days of actually just thinking about trials as trials, I don't know that I've ever thought about a clinical trial in that way for the last 15 years. I think now of clinical trials, and I tell all my patients, all the pastors, I tell everybody in the community that clinical trials these days is a continuum of care. It's not experimenting on you like you a guinea pig. The truth of the matter is, if we really want to get real about it, sometimes you're getting, and we have the data to prove it, that if you're involved in a clinical trial, your outcomes are better because you're getting more people and more eyes taking care of you. And you're getting access to some of the most, really some of the most high-cutting, most impactful drugs that you would get on a trial that you would not get when you got standard of care. So I think we're going to have to carry a message to brothers and sisters around the country that sort of says, it's like having PTSD. And, I always used to say sometimes in a bad relationship, you can be in a good one and not know it because you're still carrying your old baggage.
That's right.
At some point, we're going to have to get real, grip up, and deal with our reality right now that, to be quite honest with you, getting more of us on clinical trials is probably not a bad thing. It's probably a good thing at the end.
You mentioned earlier about in the old days, in terms of they thought the African American community's pain threshold was a lot higher, so they didn't give pain medications. That still is the case today with clinical trials. There's a tendency to give a lot less pain medication for extremely painful procedures and everything, and give them refills than they give African Americans. A lot of people don't know that when we're talking about the opiate crisis, to a certain extent, we got lucky because we're not strung out on opiates because they won't give us any.
I went through this with my own family. One of my relatives was in so much pain because he had a slip disc that ultimately got found to be a slip disc. He came in and ultimately they said, we're not going to give you any opioids. We're not going to give you anything. And they said, why not? And it wasn't because they thought that he had more pain tolerance. It's because they have this, again, this is this implicit bias. So if COVID is not teaching us anything, there were a lot of things that we as a community already knew. People are now coming late to the table, but frequently what we see with, pain medicines, the other things is that African Americans and Latinos and the Latinx sort of culture, we're getting a lot less because they think that we're going to either use those or we're going to get connected to those and become drug addicts. All this craziness cannot move unless we have moments of honesty. And I'm hoping to engage our health community and with having the community at the table so that they are, the old saying is, if you're not at the table, you are on the menu being carved up. And that's where we've been.
That's right. You're so right about it. I, as a psychiatrist, I see those people and they come to me and I said, why are you here in my office seeing a psychiatrist? And they said, well, I'm still in pain, and they telling me that maybe I'm having a mental problem. And I said, no, you're not having a mental problem. Hell, you hurt.
You hurt.
We have another question here from Tanya Hill. How readily available are clinical trials in the African American communities?
Ooh, Sister Hill just trying to keep it real. So I appreciate that. How do I answer that? Honestly, here's the way I'll answer that. Clinical trials are becoming more readily available, but they have not always been. And it's not always been the fault of where people like to blame it on our community that we don't want to participate. That may have been a little bit of it. Do you know what the truth of the matter is? It's going back to the opening discussion. Because we have diabetes at increased rates, hypertension at increased rates, these things kept us out of clinical trials. There's a host of us now, and particularly we are hopeful now post-COVID that we have recognized that if you start with the criteria that any comorbid disease, hypertension, diabetes, that, to be quite honest with you, is associated with the African American community, and you keep us out of trials, you're doing us a disservice. Now, I just want to stop 1 second and and actually get on something that when we talk about comorbid diseases, Dr. Fauci, and I love him and all the rest of that stuff, but these folks are trying to make it look like it's our problem. Let's get real. It is a problem that is constructed by essentially social structures. We can call them what they are, social racial structures.
Yeah.
Everything with redlining to us being the first, the last hired, the first fired, to having education systems that are disparate, to actually having poor access to jobs and transportation. Let's get real. These was a structure that we were in. And as a result of that structure, we actually are responding like anyone with a disadvantaged structure. So you could put any group. In fact, I told my son one day, what if we had reversed everything? And in fact, what we call Caucasians right now, white folks, they had to live in some of these areas from the 1930s and 1920s on that have persisted. They too may have increased stress, which actually impacts your epigenetic sort of makeup. And so the good genes you have some of those good genes may even be silenced and may actually increase the bad genes you have to increase risk of disease. Stress matters. So and in fact, I want to get out of this conversation that Black folks and Latino and Latinx folks actually have all this. Look, there are structures that were put in place that put us over time more at risk for having diabetes and hypertension. And I think we just need to get real with that discussion as well.
Excellent. We have another question here from Upo Basu Roy. Dr. Nguyen, now that vaccines are being developed, what are your thoughts on vaccine hesitancy in the African American community? And how can we ensure that everyone is educated and has an equitable access to vaccines?
Oh, yeah. I mean, this is another area of Jedi mind trick. We have, for real, we have now lots of people on our social medias talking about don't let them give you a vaccine and don't let them test you because they're trying to do experiments on you, just like Tuskegee. You can come up with a conspiracy theory about anything you want to.
Yes.
Except for when you're in a hospital and you're seeing the patients and you're seeing the deaths related to COVID, it stops being something that is by rumor or by, this sort of crazy conspiracy theories. I got it. We are more susceptible to conspiracy theories because some things have happened directly to us. But let's not get it wrong. The truth of the matter is, at the very beginning of COVID, we were told we couldn't get it.
Right.
The same people who are talking about the vaccines now, that, don't let them folks give you vaccine because you don't know what they're going to put in it. Bill Gates. I mean, I done heard some crazy things. Bill Gates and others going to put something in there and, come on. At some point, we got to stop the Jedi mind tricking and that's happening to us and recognize that there are vaccines that matter. Now, one of the things I tell folk, my white colleagues, is this is a symptom of not having us at the table. If you had more of us that were creating the laboratory formularies, if you had more of us who were actually developing with you those vaccines, if you had more of us in the pipeline all the way from when you were a junior person through your med school, through all the rest of these things, you probably would have more people trusting you and you wouldn't have these crazy conspiracies working negatively within our communities.
That's right.
I'm not lying that right now, Russian, all they have to do with the way we can weaponize the way we use social media right now, you can have someone who means us significant harm, putting something out there like, don't get this medicine, don't get that medicine. And then you see our increasing numbers of us dying because ultimately we don't have good information.
Exactly.
So I'm hoping down the line that as a group of what we, the descendants from Imhotep, we should know how to actually have a mind that is really good at doing critical thinking. And I think getting back to that sort of essence of who we are as Black folk and the ability of critical thinking, we need to get back in a hurry.
Exactly. We have another question here from Deidre Tate. Is there any connection between clinical trials being offered to those with insurance versus non-insured or Medicaid patients?
Man, I didn't know y'all trying to get real up in here. So the answer is to that, that it shouldn't be, the case, that is bad medicine, but I'm not going to sit here and tell you that it may not happen. The other thing that's surprising about clinical trials is that frequently when you're about to be put on a clinical trial, you should ask how much has to come out of my pocket, if any. Because sometimes folks will pitch clinical trials to you as if it's completely free. And then all of a sudden you get a bill and you're like, what just happened? So part of being I think protecting our community is also arming our community with the best possible information, that the only dumb question is the one not asked. So before someone even puts you on a clinical trial, I would certainly recommend and have those discussions about what's the financial impact. And if there is a financial impact, to say, well, I know that there are other ways of getting this done and other people who could support this through grants and other things. And so if you want me on this trial, how do you make it so that ultimately I'm not paying out of pocket? That's important. But to answer a question specifically, non-insured versus insured, it really shouldn't be a difference. I will tell you that where I practice and where I am right now, we are absolutely, again, striving to make sure that everyone who needs a clinical trial, particularly, can you imagine end-stage lung cancer? And we may actually have a drug with a small molecular targeted therapy, targeting ALK. And ultimately what happens is, as because you're an African-American, and I believe you don't want to get on clinical trials, you're not even offered that. Come on now, we got to stop playing.
Exactly. Well, we've covered a great deal, but I think that we probably better start summarizing things. Obviously, with COVID-19, we know it's important to be safe. First of all, just basic things, and we're talking about our hand washing, our social distancing, our wearing an appropriate and proper mask the right way. But I want you to also give a summary in terms of our lung cancer screenings and how important it is in terms of our general health, period. Because I think we kind of get away from recognizing the fact that our basic needs have to be addressed so that we can facilitate an understanding better of when we really need to go get screening for the things that can really be harmful to us.
I agree. And I think I'd start off by sort of saying it's not only white America that needs to get woke, it's us. First and foremost, there's not many diseases that we're not number one in. If you think about infant, maternal mortality for African-American women, worse. If you think about outcomes for lung cancer, us and African-American women, it's the number one reason of a cancer death for both groups. What's number two for African-American men? Obviously prostate, and for women, it's breast. And yet, when we think about lung cancer in our communities, it's an afterthought.
Right.
I think that when you think about our comorbid diseases, again, and I do not actually accept the fact that we are inherently at risk because we're Black or Latino or Latinx, we're inherently at risk for actually diabetes and hypertension. These are social structures that have increased those risks. But having known that, we have to grip the reality that we are at increased risk. And so get it checked out. So men in particular, to be honest with you, I might, if I'm being honest, I would say I have my days where I have to have people remind me that screening, one, it doesn't weaken your manhood at all and probably keeps you safe and keeps you around here longer to help your family. So real men want to stay on the planet to help their family. Even during COVID, the number of guys who actually had high fever and cough and the whole thing, and ultimately just essentially said, I ain't gonna do nothing about it. The number of cases that you can read about with deaths from that is going to be staggering when it's all said and done. Bottom line is, we deserve to be healthy, but even if you don't think about yourself, you need to be healthy to take care of the others around you.
Exactly. Dr. Wynn, thank you so much for this great informative lecture. I call it a lecture because we want to get the right information out there to people. and we just appreciate your expertise in this field, and just allowing the African American community to hear the truth about our disease processes and our health is just I think one of the best things that possibly we can do. As I say all the time, we are our brother's keeper, and we need to remember that. So providing this information has just been a great deal for us. We posted this Facebook Live event on our website today for the viewers. Additional resources provided by our partner, Longevity. And you can find resources at www.blackhealthmatters.com. I want to thank our partners, Bristol Myers Squibb, Longevity, MPHC, and All of Us Research. And we want to remind you to join the Black Health Matters for the 4th Black Health Matters Summit on July 18th. Come share your thoughts, concerns, questions, and others who care about what is important to you and your health at one of the most important wellness forums created for African Americans. That's again, visit blackhealthmatters.vfairs.com. I'm Stephen Broughton, Dr. Stephen Broughton, Chairman of the Health and Wellness, Kappa Alpha Psi Fraternity Incorporated, and Dr. Robert Wynn has just given you one of the best talks you'll ever hear on lung cancer. Thank you so much for joining us.